just wanted to come on here. Thank you. I just wanted to come on here and talk a little bit about aging, the aging process, our brain health, and just cognitive vitality. So I want to make this more of an interactive kind of session. So I will be mostly talking about just a normal aging process and what an abnormal aging process in regarding to the brain may look like. And that will be mostly talking about dementia and the dementia processes that we see in our practice. So if any of you guys have family members that are affected by this or are, affected by it as a caregiver or otherwise, just ask any questions. Let me know if you have any other, anything else to add. I do have a formal presentation, but we can always stop and discuss other things. So next slide, please. Thank you. All right, so before we start talking about what possible things should we be concerned about or what things would constitute as abnormal aging, we need to talk about normal aging. So as we know, we all age, and with advancing age, there are different changes that happen in many different systems in our body. So, this is not a uniform process, as we know. People age in all sorts of different ways, and that's highly reflective of where people are in terms of their genetics, their family history, their lifestyle choices, and overall their environmental exposure, where you grew up, if you grew up more in the city versus the country, and what sort of toxin substances that you may have been exposed to does matter. So, as we age, different changes happen, and physiologically, we can see those in the different systems in our body as well. So some of these changes are considered normal as part of the aging process, because as we know, we age, but also our cells and the processes that they control throughout this also age as well. So some of these changes that we see include circadian rhythm. So this is, our day and night kind of like a reset system. So as we age, a regulation of our body temperature changes, and our sleep cycle is also changing. And sometimes we are noticing that as we are getting older, we tend to fall asleep a little bit faster and earlier as well. And that's something that we see. The GI system, this is the we're talking about our GI system, meaning our swallowing, our digestion, and everything that's involved there. And some things that we see and hear involve our muscle system. So when we're swallowing, and as we're aging, some of the muscles can change and that they atrophy, or they can also thicken. And because of that, our ability to swallow or ability to move food from our upper part of our GI system to our stomach is kind of like impeded. And this can result in GERD or gastric reflux, which we see a lot of people as they get older deal with this. And, different sorts of heartburns and things like that can result from this as well. Next slide, please. So some more things that we are going to discuss, our renal system. So this is our filtration system, mostly our kidneys. So as we're aging, our kidneys reduce in size or they atrophy. So that means that we're losing functionality in terms of being able to filter some of the toxic substances that we may be ingesting, or some of the medications that we take as well. So the ability of the kidneys to do their job, even though we do have a good amount of compensation, that can decrease as well. And here we see it where small insults can be harder to recover as we age. And for example, something very simple as dehydration or not consuming good amount of water as we age can really affect our system, our system in a major way that it wouldn't have had if we were a few decades or a few years younger. In terms of our heart and our cardiovascular system, with age, increased risk for cardiovascular disease increases, CAD increases. So as we're aging, our blood vessels are hardening, so they're not providing enough blood flow to our heart. So that's where we get increased risk of heart attacks. And there are some changes that occur within the muscle system of the heart as well. So our GU system, this is our urinary system. Once again, with the changes in muscle that we can see, people experience incontinence, and also with the hormonal changes that we see, especially in women with estrogen, this incidence of incontinence is also higher as well. So one more thing to talk about before we get to the brain is our musculoskeletal system. Here we see loss in muscle mass. So our muscles tend to atrophy, muscle quality increases, and it's infiltrated by fats and other connective tissue. So we're not really as strong as we used to be, particularly if we're not really working on training our muscles and bones. And in addition, as we're aging, the probability of bone fractures is increasing, and the rate of repair is also slowed as well. Next slide, please. So let's talk about the brain. The brain is a fascinating organ. So think about everything as humans that we do is coordinated by the brain. And the brain is just this little structure. An adult brain usually weighs about 3 pounds. And within that is where our thought, memory, emotion, our ability to recognize others, touch, motor skills, vision, pretty much all human function is controlled within the brain. So the brain is made of gray and white matter. So we have our outer part of the brain, which is the gray matter, and the inside, which is the white matter. Our gray matter is made of neuronal cell bodies. These are just the basic functioning units of our nervous system. And the white matter is also the tracts that allow these several neurons to communicate as well. In our brain, how it does this, or how it communicates, how the different neurons communicate, is by using different proteins as a chemical messengers. That is the way, the mode of communication of our brain. And it is estimated that our brain consists of 86 billions of neurons. And then when you add the different connectivity amongst these neurons, this can add up to 1 quadrillion connections. To be honest, I don't even know how many zeros that is, but that's a lot of zeros. So, which is why I love the brain. It is, as much as we know about the brain, there's still a lot that we don't know. So there is a lot to learn. Next slide, please. Okay. So when we talk about the brain, we talk a lot about structure and function. So through studies, through different sorts of functional MRIs, we know and controls what sort of function. So we're just gonna try to, I'm gonna try to keep it not so specific, but let me know if anybody has any questions. So at a higher level, our brain has different structures, what we call the cerebrum, the brainstem, and the cerebellum. So the cerebrum is what we consider our human part of the brain. So this is what us humans, obviously, just like what we talked about, our language, our emotionality, our ability to recognize others, and our ability to communicate is controlled by this higher brain, or the cerebrum. The brainstem is a deeper part of the brain structure, and this is more of what we consider our primitive brain. This controls our breathing, our heart rate, and some of those structures that don't necessarily, that of course help us function, but they're not of the higher structure. And cerebellum is the other part of the brain that's located in the back of our brain that controls our movements and kind of coordinates how all of our movements are actually going to be as we intend them to be. So talking about the higher brain, or the cerebrum, it has 4 sections. These are called lobes. We have the frontal lobes that are in the front, the parietal lobes that are kind of like higher, and to the side, the temporal lobes right by our ears on both sides, and the occipital lobes, which are in the back side of the brain. And each lobe has a specific function. So the frontal lobe is the largest part of the brain. It's located in the front of the head, And it is involved in personality, characters, decision-making, movement, control smell. And this is also where Broca's area is located, and this is associated with ability to produce speech. And some of the functions of these brain structures becomes apparent when we see brain changes or atrophy or shrinkage in different parts of the brain, and the resulting kind of like deficits that could come from that. The lobe is the middle part of the lobe, the middle part of the brain. It usually helps us identify objects, understand spatial relationships, understand left, right, like a 3D kind of understand our world in 3D, I guess I should say. It is also involved in interpreting pain, touch, and this is where what we call Wernicke's area is located, and this is the area that actually helps us understand and interpret speech. So the occipital lobe, which is located in the back, is what helps us understand our world through our vision, which is our eyes, and the temporal lobe, which is on bilateral sides by our ear. It helps us with our memory, speech, because it connects the two parts of our speech areas, that part that produces speech and the part that actually helps us understand speech, musical rhythm, and it does have some degree of smell recognition as well. Next slide, please. So this is just a depiction of our human brain and some of the different lobes of our higher brain function and some of the other structures that we just discussed. Next slide, please. So before I go to the aging brain, does anybody have any questions, concerns, anything you want me to address before I go on? And I cannot see the chat, so if there's anything else, just let me know. If not, I'll just go on, and then we can also have a different session for questions and stuff at the end. So talking about the aging brain. So just like, we talked about systemically, there are several changes that happen as a part of the aging process. There's also normal things that, normal as aging can be, of course, things that we can see as we get older. And some of that is the volume, just the size of the brain tends to decrease. Actually, after the age of 65, it is shown to be decreasing at about 7 centimeter cubed per year. And with a lot of this loss happening in our frontal lobes and in our temporal lobes. And this becomes important because these part of our brain structures control a lot of our human functions, particularly the frontal lobes, which help us in language recognition and basically a lot of our higher sort of human functions. In addition to that, cerebral blood flow decreases to our brain. And then because some of the other physiologic functions that help regulate how much blood flow our brain gets with our vasculature hardening and other things can tend to age with that process as well. And because of that, our brain may not be getting optimal blood flow that it needs. That's something that we see, but it's considered as part of the normal aging process. The other ones are age-related neuronal loss. So sometimes the neurons just shrink and die with the aging process. And then at times, then our brain is working harder to kind of like do the tasks that we used to do much easier when we were younger. In addition to that, we've looked at different functional MRIs, and our brain connectivity, or how one part of the brain communicates with the other part of the brain, is also altered as we age as well. So in terms of our memory, and our cognition, or our ability to process this information, some things are not as much affected by the aging process, such as procedural kind of information. And that is, when you're learning something, you're not just storing the memory of it, or if you're associating a particular action, let's say, learning how to ride a bike. That is something that you learn when you're a kid, and you may not be doing it often, but whenever you get on the bike, it might take a couple of minutes, but a lot of us tend to get on there and then we kind of remember how to do it. So when it comes to memory actions that are associated with, procedures or long-term things, a lot of times as we're older, this does not tend to be affected, or naming, or things that have been a part of our lives for a long time usually are preserved with the aging process as well. But what is affected is some of the memories that are short term, such as events and things that may happen, can be affected with when our brain is aging or shrinking. And also processing speed of information can decrease with age as well, which is, sometimes we find it hard to remember how to do things, or sometimes we find it hard to put information together as easy as we used to, because the speed of how we do things is definitely affected by the aging process. Next slide, please. So, that what we just discussed is what we consider somewhat of a normal part of the aging process. And we have what we consider pathologic aging, meaning that, what's happening is actually more severe than what we just see physiologically or with physiologic changes. And these are disease processes that occur because of age, but they're distinct from the changes that are associated with normal and healthy aging. And with brain aging, of course, what we always talk about or discuss is dementia. So dementia is a disease process, as we'll discuss in just a minute. It is an umbrella term. It's not a single disease process. It's seen by reduced or decline in cognition function, meaning ability to do things, memory loss, or behavioral changes that are due to biological changes in the brain. And this disease process is a gradual onset. It's slow and insidious. It's not usually abrupt. One day, like a person may be normal versus the next day they have dementia. That it's not like that abrupt of a disease process. It's usually slow and smoldering for some time. And some people may have an ability to mask it depending on, their daily function and what they do for a living. But it's usually an ongoing process, and it's masked sometimes years, sometimes decades down the road. And multiple causes of dementias exist, but the most common, or the number one cause of dementias is Alzheimer's, which we'll discuss in a minute. And sometimes what we consider reversible causes of dementias do occur. And that is in medicine, where patients may come and they may exhibit symptoms of dementia, meaning, they may have like memory impairment. I don't know how to say memory loss, but memory impairment, processing inability, and a lot of their brain functionality is not what it used to be, but it's not necessarily because of their brain being affected by a process within the brain, but it could be other things that are affecting the brain. And good examples of that may be some derangements in some metabolic processes, sometimes like thyroid derangements or other hormonal derangements can definitely present as a dementia-like process. Sometimes it is lack in some very essential vitamins and nutrients can present as dementias, but then, that's how we identify if this is more of a smoldering dementia process versus if this is something that is reversible, is by really understanding, the age of the patient, the symptoms and how long they've been going on, and understanding overall what other things may have happened that led to that presentation. So this is more of, again, a continuum. So someone first may be somewhat impaired, and we start with, go back. Thank you. So looking at the continuum at the bottom, so we start with mild cognitive impairment. This is patients may have impairment, but they don't really have any difficulty doing their activities of daily living. They're able to do things as they normally would. So we usually don't capture that, and families don't really do that, don't really notice that as well. So then we proceed into mild dementia, moderate, and severe dementia. And that's when we see patients' impairments in their daily functioning, their ability to handle their finances, and other things that we will shortly talk about. So just to drive up drive home the point of dementias are usually a long-term kind of process. Next slide, please. So just like I just said, dementias are an umbrella term, and I'm going to mention the few or the most common ones that we see, but there is, in terms of identification, there's more than 100 causes of dementias identified with several different disease processes, but the number one cause, as we just discussed, is Alzheimer's dementia, which we'll talk about what that is caused by. The second most common is vascular dementia, and it is as a result of cerebrovascular disease, meaning that this is what we see in patients when they've had multiple strokes or even very debilitating one big stroke. So because of that stroke, of course, that part of the brain that's affected dies, and depending on where the stroke occurred, it could be the part of the brain, that processes information, or that controls their language, or their other abilities. So in that case, we term that as vascular dementia. The other dementia that we see is alcohol-related dementia, and this is with lifelong term use of alcohol. Alcohol in itself is toxic to not only the brain cells, but a lot of other functioning of our body. So because of that, people can present as dementia, and this is most of the time irreversible. In addition to the sheer toxicity of alcohol, a lot of times when people are, chronic alcoholics, they don't tend to take care of themselves or have adequate nutrition. So there's a couple of other disease processes that are within the realm of alcoholic dementias as well. The other common one that we see is called frontotemporal dementia. So this one is recognized by atrophy of the brain structures that are the frontal lobes and the temporal lobes. And just like what we discussed, as the brain is shrinking, or as those neurons are dying, the ability of the brain to process information and to carry on the functions that it used to will not happen anymore. So in the case of frontotemporal dementia, people will have change in behavior because of, the atrophy of the frontal lobes. They have impairment in speech, or like what we call primary progressive aphasia, because our speech centers, meaning our speech production centers, are located on our frontal lobes. And then other aspects of language production or lack thereof can happen in that dementia process as well. Next slide, please. Alicia, can you go to the next slide? Thank you. Okay. So talking about Alzheimer's disease. So Alzheimer's disease is the most common cause of dementia, and it usually manifests as selective memory impairment. So, people will have difficulties remembering. First, they will have difficulties remembering short-term memories. They're episodic, meaning what happened, where, and those kinds of things. And that, after it starts that way, can then progress to involve long-term memory. People can have difficulties doing their daily activities. They may have difficulties even recognizing themselves and other loved ones. So it usually starts with the short-term memory and difficulty with, things that people used to pretty much do every day. The onset of this is usually around 60 years of age. However, this can be seen in younger patients. And usually when it's a younger or early, what we term an early onset dementia, this is usually associated with a strong family history of dementias in the young, and this usually has a genetic component to it. So in terms of pathogenesis, so the reason that Alzheimer's disease results is, at least as far as we know, there's still a lot of research being done in this topic, and it's overall unclear, but as far as we know, this is because of an abnormal production of proteins that are called amyloid proteins. And these, because they're not being adequately cleared by the brain, they can be neurotoxic. So they can damage the different parts of the brain and its functionality, and they just tend to accumulate over time. In addition to this amyloid protein that is abnormal, there is also another protein that's implicated in Alzheimer's disease, and this is called tau protein. And this is also when it's accumulated, it impairs normal neuronal functioning and communication among the different parts of the brain, impeding functionality. So some of the genetic, at least aspects that are implicated in Alzheimer's disease is a gene called ApoE4. And this is just involved in, once again, being able to clear this abnormal amyloid protein. And when that's not cleared and then when it's accumulating is when we have, loss of functionality and neuronal toxicity and neuronal death. But other risk factors for Alzheimer's dementias include, diabetes, smoking, hypertension, hyperlipidemia or high cholesterol, obesity, depression, sedentary lifestyle, inadequate participation in mentally stimulating activities, also believed to be a cause of Alzheimer's dementia as well. Next slide, please. So just like we discussed earlier, Alzheimer's is usually a long process, and a lot of times we tend to see patients in the middle to late stages than early stages, unfortunately. So in the early stages of Alzheimer's dementia, a lot of things that we see are things such as people needing reminders for their appointments, their daily routines, which is something that they've done their whole lives every day, which can be, for some of us, as simple as waking up and brushing your teeth. It can be difficult. Concentration can be difficult. Participation in, conversations with families can be difficult. And a lot of times families see that their loved one is a little bit withdrawn when they're around family. They're just not participatory with, whatever's going on as they normally would, because they're just having a hard time keeping up. And that's usually the early stages or signs of Alzheimer's dementia. In the middle stages, then patients usually are requiring hands-on care so that, for their activities of daily living, so that they can get cleaned up and they can get dressed so that they can eat, because they are progressing to where they are not remembering or aware of how to do those daily functions. And we can also see changes in personality in this stage. In the later stage, there is severe confusion. Here, patients require hands-on care for most of their personal care. They may not recognize themselves, family. A lot of times, patients will have difficulty eating. They will have difficulty getting out of bed. And this is the very severe stage that we see as well. So how we diagnose Alzheimer's disease is a multidisciplinary approach, meaning it's really not an easy diagnosis. So it is very imperative to have family there so that they can talk about their loved one and some of the changes that they may have seen in them in terms of their personality, their memory, their activity of daily living. If they used to work and they're not anymore, what was the cause of that? If they used to drive, what had happened? If they're lost, for example, in routes that were familiar to them before. So those sorts of things, we try to get a full history, how long have been going on, and so that we can get a clear picture of where the patient may be on the stage of Alzheimer's disease, and to make sure also we have the accurate diagnosis as well. So after that, we oftentimes, if not all the time, do a cognitive assessment. And this is a formal neurocognitive assessment by neuropsychiatrists most of the time, and this is an in-depth assessment of the person's ability to function. So they put them through testing that assesses their short-term memory, long-term memory, math skills, other cognitive processing skills, speech, so that they can get an idea. Of if this is a true dementia-like process versus something else, and also so that it can give us an idea as to what type of dementia process we're also dealing with as well. So we check lab work just to make sure, once again, because there are other mimickers that could manifest as dementias, and they can be a simpler fix as, making sure that some of our essential nutrients and vitamins and all of those things are depleted, or, our hormone is most of the time our thyroid is well balanced. So that can affect our, memory and cognition as well. So we check some lab tests. We make sure that their medications are reviewed, because a lot of times medication side effects can present as a memory impairment or a cognitive type of process. When we actually look at it, it's because the patient may be on too many medications that are actually impairing their function. So that is all of the things that we do to diagnose dementia, because if we are truly to diagnose Alzheimer's dementia, for example, the only way we can do that is by taking a post-mortem biopsy. So taking a sample of the patient's brain and actually looking at it under the microscope and making sure that these abnormal proteins that we just talked about are there or are not there. So that's the definitive diagnosis. But most of the time with this multidisciplinary approach and making sure that neurologists, neuropsychiatrists, and other members of healthcare are involved, a lot of the times, more than 90% of the time, that we are able to recognize and accurately diagnose Alzheimer's dementia. Next slide, please. So these are just some images that I drew. The Alzheimer's Foundation, it's a great resource, and they have the most up-to-date information. So the first graph kind of reflects the impact of Alzheimer's, and the first graph is actually a 2020 data, but the other two are from 2022. So just comparing age of patients that are affected by Alzheimer's disease and some of the healthcare resources that we actually spend on Alzheimer's disease, as well as numbers as it stands right now. So looking at the first graph, mid-60s to mid-70s, definitely that's usually where we start to recognize and see the dementia-like process or Alzheimer's most of the time. And then as age increases, as the aging process also increases, those numbers become higher and higher. And of course, as we're seeing in the numbers, especially in the group that's 75 to 85 and 85 plus, the patients that are mostly affected by Alzheimer's disease are African Americans and Hispanic patients. And looking at the pie chart that's on the top, where it is mentioning healthcare cost in 2022. So in 2022 alone, the healthcare cost because of Alzheimer's disease was $321 billion. So it has a huge impact on our healthcare system. And looking at the number of people that are diagnosed with Alzheimer's dementia 2022, in total, 6.5 million patients were diagnosed with dementia, Alzheimer's dementia particularly. And looking at it once again, as the age increases from 65 to 75 and to 85, the numbers also increase in that aspect as well. And when we're talking about these numbers and also these numbers that reflect our healthcare costs, this is not including health caregiver kind of like burden and the amount of productivity and the amount of money that is lost in that too, because a lot of times, there are obviously family members that care for these patients, and they're missing work, they're missing school, and they're missing their productivity years because of having to care for their loved one that do not have anyone else to care for them. So in terms of impact, it's actually way larger than these numbers reflect. Next slide, please. So speaking of Alzheimer's disease and minority populations, just like the graph before reflected, African American and Hispanic patients are by far the most affected by Alzheimer's dementia. And according to the Alzheimer's Foundation, while African Americans are about two times more likely than whites to have Alzheimer's and the other dementias, they're only 34% more likely to have the diagnosis. And that is, of course, when we're talking about healthcare disparities and the fact that we're not reaching our these patients, particularly in early stages. And when they're diagnosed, African American and Hispanics are typically diagnosed in the later stages of the disease when they are more cognitively, physically impaired, and therefore are in need of more medical care. When we're looking at the numbers, though, it's important to recognize that other than healthcare ability, healthcare access to these patients, genetic factors do not have any account in the greater prevalence of Alzheimer's disease to these populations versus our white patients. So it's just a sheer factor of not having healthcare access, not having the resources that are needed to, first of all, diagnose these patients and provide them with resources not only to help kind of slow down the progression of the disease, but also be able to provide them in ways that their health in the future and this disease is not negatively impacted. In addition, high blood pressure and diabetes is suspected risk factors for Alzheimer's in our African American populations as they are more prevalent. And diabetes is more prevalent in the Hispanic community. These conditions, among others, may contribute to a greater prevalence of Alzheimer's among these groups. In fact, some studies suggest that adjusting for the health and socioeconomic risk factors, if we were to adjust for that, no differences in Alzheimer's would exist. So as a result, better management of these risk factors, particularly high blood pressure, diabetes, may reduce the risk of Alzheimer's disease and other dementias among African Americans and Hispanics. Next slide, please. So Alzheimer's disease and the other dementias do have a huge impact on our healthcare system. They have a huge impact on families and patients in general. And as of right now, we do have treatments that we have been using for a while. A lot of these, we use them to try to slow down the progression of the disease. And we're hoping that they somewhat work, but we don't really have a cure or treatment for this. But there is a lot of treatment modalities in the pipeline. There's a big movement, there's a lot of funding so that there are ways to not only figure out more markers for Alzheimer's disease so that it's diagnosed early, such as using simple blood tests. And then more research is underway to actually confirm or before postmortem autopsy be able to really understand the depth of the connection of these abnormal proteins that we attribute to Alzheimer's disease. So there's a lot of research underway, and this is data from 2021. So as of 2021, there were 129 studies in phase 1 trials, 191 studies in phase 2, and then 62 trials that have made it to phase 3, so that there can be different drugs or medications that can hopefully help with curing this disease, or be able to diagnose it early so that we can do something about it. And there's a few newer treatments. I didn't put them in the slide because they're not fully FDA approved as of right now. And they're kind of, people are, I guess in the world of neurology, we're still not sure about them yet because they're quite new. So we're still looking into that. But as of right now, there is no cure or treatment to cure Alzheimer's disease, I guess I should say. Next slide, please. So let's talk a little bit about cognitive vitality. So we talked about, normal aging and pathologic aging and what things to look out for, but how can we preserve our health, most importantly, our brain health, and be able to, live longer and fuller lives without, with also decreasing our risk for neurodegenerative kind of diseases such as Alzheimer's. So we have to focus on our overall health and also our brain. And, in addition to some of the genetic predispositions that we discussed for Alzheimer's, a lot of the other risk factors are lifestyle factors. So, risk factors being diabetes, high blood pressure, high cholesterol, not moving enough, or being sedentary. All of those are risk factors. So because of that, trying to maintain a healthy lifestyle overall will also be healthy for our brain as well. So how we focus or care for our brain: one, physical exercise. So, our brain, even though it's a 3-pound little thing, 25% of our blood flow goes to the brain because the brain consumes oxygen. So any activity that increases our heart rate is healthy for our heart, is healthy for the brain, and that is important. The next is diet and nutrition. So our brain is actually 60% of fat, and that actually helps our nerve cells or neurons to communicate faster because they have a covering or a sheet that's made of mostly fat. So a diet that's rich in healthy fats, lean proteins, vegetables, fruits, and fibers, and low in saturated fats and processed foods is important for overall health and our brain health as well. And the other things that we believe slow down, cognitive changes, as well as any sort of dementia-like process, is cognitive stimulation. So this is learning a new skill, learning a new language, reading, being open to different experiences, traveling, learning new games, and just kind of like a fulfilled life overall is believed to be a protective against dementia-like processes. In addition to that, social engagement is very important. So visiting friends, family, any sort of meaningful connection is important because, I think sometimes life and, work and other things can be very isolating to some people, but we're human and we are social beings and we're meant to live with others and community and in other things. So just being socially engaged with others, such as with volunteering or some things that, allow us to interact with others, also is believed to slow down cognitive decline and also protect against dementia-like processes. Next slide, please. So just a little bit of tidbits as to things to watch out for in our loved ones that could be a sign of a dementia-like process as they age. So some memory loss affecting activities of daily living. So having difficulty, once again, doing the things that people were able to do without even having to not think of it at all. That should definitely alert us. Having difficulty in, cooking, dressing, and those kind of things that are definitely out of the norm should definitely concern us. Problems in abstract thinking. So, for some people, they are the financial person of their family. So they're the ones that pay the bills, write the checks, making sure everything is done. So what some things to watch out for there will be, if a bill is late and they're not even recognizing that they are late. A lot of times that, like when, especially early on, if nobody else is watching them do it, and, can definitely get missed and can get backtracked. So making sure that they're able to actually do or handle their responsibility as they would. And if they're not, we should definitely have our ears perked as to what may be going on. Again, difficulties performing simple tasks. Some people, have difficulty picking up the remote control and don't know how to turn on the TV. And sometimes they can mask it very well, but that should definitely alert us to think that something may be going on. Language problems. So identifying what things are called, what they do, those kinds of things are what we mean by that. They're disorientation and impaired judgments. Disorientation, most of the time we see this in people just not even recognizing their surroundings, their house that they lived in for multiple years, really not recognizing where things are kept, even though they have kept certain things in their place and they've known that for their whole lives pretty much. Impaired judgments, buying things that they normally would not, spending lots of money, when that is definitely out of the norm for them. Other things to note would definitely be behavioral changes, again, feeling more withdrawn, anxious, depressed, other personality changes, being short fused when it was not their norm before. And once again, being withdrawn from family just because they're not really able to keep up with conversation and other things going on are definitely things to watch out for. Next slide, please. I think that's the last one, if I'm not mistaken. Awesome. Yeah, the Alzheimer's Foundation has, again, excellent resources. Not only do they have resources for patients, they also have resources for family and caregivers. They have support groups that are in different local areas that they can work with people with, so that they can actually take a break from having to care for their loved ones, so that they can actually breathe and can tend to so that they can take care of what they need to do in life as well. So that is a website that I would definitely recommend. And if there's any concern with a family member or a loved one, I would say definitely talk to your family physician, because that's mostly where things start, so that we look into some of the reversible causes that we talked about. And then after that, then the patient may benefit from assessment from a neurologist, that they can do a more in-depth testing, ask more of the in-depth questions, so that we can get to the disease earlier. And we're definitely hopeful that in the next 5 to 10 years, there's going to be significant shift in this disease, just because there's a lot that's going on right now, so that we can help patients better and help families better, and hopefully improve their health as well. So if you guys have any questions, concerns, or anything else anybody would like to share from their personal experiences, please feel free to.
I have a question.
Yes,
A
ma'am.
long time ago, my father was on a medication called Aricept.
Mm-hmm.
Do they still use that now, and does it work?
Yes, so that's Aricept, or donepezil is one of the medications we use, and we've used it for a long time. The other one is called Namenda, and those medications have been used for multiple decades, and they're quite cheap. And we do use that, and we believe that it can slow down the process of the cognitive decline, but it's certainly not a cure. And right now, we use those medications because we don't have any other options. And they're, in range, they're harmless medications overall, or I should say with not as many side effects. So we're trying to do anything for the patient, but most certainly they haven't necessarily been proved. They have not been proved to show any significant improvement or change for the better in that aspect. But yeah, we use it a lot. It's kind of like a Hail Mary type of thing.
Okay. Also, recently, my she had the confusion that you mentioned. She said she came out of her bathroom and did not recognize her apartment, and she's been there for years, and
Okay.
it scared her.
Of
And
course.
I told her she should tell her doctor, but she said no, she didn't want to do that. That was the only time that has happened, as far as I know.
Okay.
But if it happens again, should I reach out to her doctor?
If you are, one of the family members listed that, you can talk to her family physician because of HIPAA codes, I would definitely keep an eye on it. And if there is anything else, not even just that period, like that active disorientation, if there's some things that she's exhibiting, definitely be watchful for that too. And if it's happening more often, I would say at least try to convince her to talk to her doctor. If not, you may also consider talking to them as well. And the reason I say that is because, sometimes, of course, as common as, some of these Alzheimer's and other dementias are, there are some simpler and easier fixes that could be. but we also see it in patients where they don't want to be honest with their family physician because they feel like they're going to lose their independence and they won't be able to live in their home and do the things that they would normally do. So it's just something that we have to balance. But I would say definitely be watchful of anything that you may notice that is out of the ordinary for her, and try to let her know that, it is important for her safety to be able to reach out to her PCP. And if you tell her, if she doesn't reach out and you may reach out to them, maybe she'll talk to them.
Okay, thank you.
Yeah, you're welcome. Anybody else have any questions, comments about anything?
Yes, today, can you speak to mental health diagnoses and how they might affect your cognition with aging?
Yes, absolutely. So we actually have a term in neurology that we call pseudo-dementias. So pseudo-dementias are, disease processes that can pretty much present as one of these dementias that we talked about. They impair memory, cognition, ability to function, but the cause of it is not necessarily anything structurally wrong with the brain, such as the subtypes of the dementias that we talked about. It is usually seen in untreated or undertreated anxiety, depression, and a lot of times PTSD, people that have faced a lot of abuse in the past. So we see it a lot. And the reason for that is, when things such as depression, anxiety, and all these other mental health issues are not optimally managed, it can certainly cloud your judgment. It's going to interfere in your ability to function as you would best. So in a lot of patients, when they come to us with the concern that, their family's concerned, like they may not be remembering things or they're acting a little different, we have to do a thorough evaluation and see what else is going on. If there are any stressors in their lives, if there's any family changes, or anything, so that we can get into the deep root of it. And a lot of times, once we have kind of addressed that by getting them plugged into either a counselor or a psychiatrist and making sure that, whatever is the underlying cause of it is either treated or good enough to be treated, then they tend to improve and resolve. So that is actually another thing that can definitely mask as a dementia-like process, simply because, when you are extremely anxious or living in depression, you are not processing your world as you normally would. And of course, that's going to impair your ability to work, your ability to interact with your family members. And it's not necessarily a dementia-like process, but the lack and overage of the neurotransmitters that are implicated with depression and anxiety can certainly mask as those. So yeah, unfortunately, we see that a lot too. And it's good to be mindful of. And that's why, whenever there's any changes with your loved one, be mindful of that too. And, some of the other things that may be going on at home that could be contributing. And also the timeline will be helpful with that too.
Are you going to be sharing your slides? There were some things being covered when we were watching it and we couldn't get all the information.
Yeah.
Are you willing to do that?
Yeah, we'll probably put it on the website. We can definitely put it on the website. When I was presenting it, I noticed some typos. I will correct that and then we'll put it up there.
Okay, thank you.
You're welcome.
Are there any other questions or comments for Dr. Tsedey? Well, I want to say thank you all so much for coming with us, and apologies for running behind the scenes. Technology was technologying against me today. I am so sorry, but Dr. Tsedey is full of amazing wisdom and clearly very passionate about the brain and cognition and our health just comes with such a vital organ. So thank you all for coming and being a part of our outreach. I've placed our website in the chat. You will find once the slides are edited to her liking, we will share our information as well for any ongoing outreach that we do. We totally invite you to come and be a part of it. So again, thank you for being here, and we wish you all a good night.